What we do with babies and young children is we start them at about 2 liters per kilo per minute. So yes, we'll start them, 6 kilo baby, we might start at 12. And that's what we do, is we try to just titrate them down. But we do start them on the high side. And the beauty of it is because it's not a closed system, you're not worried about creating a pneumothorax.
So what surprised me about precision flow and Hi-VNI technology is, one, the simplicity, and two, just how effective it was. To me, it looked like, I originally thought that this was going to be a nasal CPAP, or this was going to be a high flow device, and I thought that I could use it as a humidifier or to treat hypoxic patients a little bit more effectively. I never imagined that I could use it for CHF or some of the sickest COPDers. As a matter of fact, they taught me initially that there was a segment of people that would be too sick for it, that would have to go on positive pressure or CPAP or BiPAP. The more patients that I treat with Hi-VNI technology, the smaller that group of people are. So I've treated some of the sickest COPDers with PCO2s greater than 100 successfully with Hi-VNI technology. I've treated small babies. I've treated folks with mixed CHF, COPD, and pneumonia, respiratory distress of all types with great success. What patient types or demographics or illnesses would be particularly benefited from Hi-VNI technology? I would say that some of the smallest children are the most difficult to treat because we just don't have a lot of modalities. These are folks that you don't routinely put on a mask, right? These are not folks, little ones that are going to tolerate positive pressure very well at all. They're going to struggle, they're going to move about, they're going to try to rip that mask off. And it's not something that we routinely do in the ER. This gave us a tool to finally treat that patient, right? Before Hi-VNI technology, we were really relying on suctioning and nasal cannula oxygen. If they were too sick for that, oftentimes they were being intubated. So I believe that we're intubating less children. I believe that we're providing a higher modality of care. We're certainly increasing the satisfaction of their parents, and we're noticing a lot more benefit to the children. Similarly, the sickest people or the most elder, these folks don't tolerate masks well at all. And they do very well on Hi-VNI technology. A nasal cannula is simple. A lot of them are used to it already. They kind of enjoy the heat and humidity that comes along with the therapy. It allows them to clear their secretions. They can cough. They can take their oral medications, which ends up being cheaper on the hospital side of things. And moreover, they don't have to go to the ICU. So this is a benefit to us, in particular with our children. They no longer have to be transferred for pediatric ICU. So they can stay out in the community. We can care for them here, which is a big satisfier for their parents as well. Precision flow offers the ability to change 3 values. One is the temperature, and most of my patients I treat on about body temperature. I stick to about 37 degrees. Sometimes folks that are on chronic nasal cannula oxygen like their temperature's a little bit cooler, but otherwise I don't touch that. Second, their flow. The flow really depends on the amount of therapy that they need. Most folks, if I'm going to initiate therapy, I'm going to start right at the max therapy, 40 liters, which is as high as precision flow goes, because I want to treat those patients most effectively right up front. This isn't like non-invasive positive pressure where we kind of start at a pressure that they can tolerate and try to ramp it up. It's totally different. You're going to get max therapy right away. And then if you want to back it down, and I do sometimes mostly for noise, those folks have some difficulty hearing, and so I turn that flow down. But only after they have really turned around and you're starting to see the benefit of Hi-VNI technology. The FiO2 is separately adjustable, which I think is really important for folks with COPD that may be oxygen sensitive. So what I've found is that if their exacerbation is mild, those folks will do at or better than the oxygen level that they're on at home. So if they're on 3 or 4 liters at home, you're not even going to need that much when you put them on Hi-VNI. So how have I used Hi-VNI technology in pediatric patients? Before Hi-VNI, before Precision Flow, I really didn't have a lot of options to care for the sickest of kids, right? A lot of these folks were either being treated with nasal cannula oxygen and suctioning, or they were being intubated early. Now we have another tool in our chest, and Precision Flow has been a great option for them. They tolerate the nasal cannula much better. They don't fight it. They enjoy the heat and humidity that it provides, and the therapy has been really effective. Oftentimes these children have a lot of upper airway secretions that they're able to clear a lot more easily. Also, their parents can interact with them, right? They're not going to be behind a mask. They're not going to be fighting the mask, and they can be held or carried or moved about as needed. In terms of how effective it is, it's been wonderful. We care for pediatric patients on our floors. We don't have to transfer them to pediatric ICUs. And it kind of runs the gamut in terms of what diseases we can treat with them. We've treated pediatric heart cases. We've treated pneumonias or bronchiolitis or flu, or you name it. Any kid with respiratory distress has done really well on Precision Flow.